Welcome, everybody, and welcome to our guests online. It is my pleasure today in our inaugural Grand Rounds on this important 10th anniversary year to welcome a distinguished guest. Dr. Yele Aluko is a physician, well-known executive and health industry strategist, and especially focused on global health equity. With a great deal of background in advocacy. He formerly was the managing director and chief medical officer at EY Americas. He is the founding director of the EI Center for Health Equity. We're very, very pleased to have him with us today. His background in leading enterprise-level strategies to address disparities in healthcare delivery and outcomes can answer some of the questions that we all have. May I invite some of you to sit in front, close to our distinguished guest? Can I do that? We have some very important guests with us today, but they're very shy. Margaret, it's especially you, addressing you. I'd like to see you close to us up here. Don't be shy. Dr. Aluko advises healthcare system executives on industry, megatrends, transformational strategies, and innovation to drive sustainable growth and equitable care. Prior to joining EY, spent over 2 decades in clinical practice and physician leadership at a 10 billion integrated healthcare system. I don't know how to describe that, but it is part of the solution, but also, can I say part of the problem? Yeah, and in the southeastern United States, where he led the growth and integration of its heart and vascular service lines across a 15-hospital network. I would say that his comments today are particularly relevant because of his background in industry and as a practicing physician, but also as a strategic thinker and a planner. We are very, very excited about having you with us at the school today and hope that you will become one of our friends, one of the friends of the Public School of Public Health here in New York at City University of New York Graduate School of Public Health and Health Policy. I was very, very pleased to have the privilege of meeting you in person and gleaning the kind of genius that you bring to leadership, but also your personal humility and intelligence, which I think we will all benefit from today. So may I humbly welcome you to the podium. I'm very excited to hear what you have to tell us today. Thank you very much.
Well, good afternoon, everybody. It gives me great pleasure to be here with you today. I'm humbled by your invitation, and it was a very warm lunch we had together over a good conversation. Today, my talk is themed Health Equity at a Crossroads, reframing the conversation for universal value. And my goal is that after this conversation, we'll walk away empowered with new thinking and achievable roadmap toward measurable health equity impact. And we have a lot to cover today, but we have enough time to do so. I'm going to begin with grounding ourselves in the health equity context. We must ask ourselves why recent progress toward health equity has stalled. We will revisit our historical narrative, and we'll reflect on if and how we must reframe that narrative so that detractors and no longer regard us, our message, and our work to be, as has been described in Shakespeare's Macbeth, as a tale told by an idiot, full of sound and fury, signifying nothing. Move forward, we need to pivot from eloquent rhetoric to enduring results, building broad alignment with health system leaders, decision makers, and those who control investments in programs and in initiatives. When we examine state-level health rankings, it is clear that health outcomes vary widely for reasons beyond race. I should say it should be clear that health outcomes vary widely for reasons beyond race. But in several circles, there's a misconception that race is the reasons why health disparities exist. We should ask ourselves, why are states like Hawaii, Washington, Minnesota, Utah, Colorado, Massachusetts, Connecticut, Rhode Island, New Hampshire, and Vermont, you see these states in light blue shade, why are they consistently among the healthiest American states? While Oklahoma, Arkansas, Louisiana, Mississippi, Alabama, West Virginia, and New Mexico rank the least healthy. These are in the dark blue shade. Now, truth be told, America has never been truly healthy, especially when measured against global benchmarks. Life expectancy, a core metric of system performance, tells a story. In 2023, white Americans averaged a life expectancy 77 years. Now, this is far below Switzerland and Japan's best-in-class outcomes of 84 years life expectancy. And you all know this, that despite the US spending 17% of GDP on health compared to Switzerland's 12% and Japan's 11%, Switzerland, Japan, and other high-performing nations invest in integrated systems that combine universal coverage with prevention and systemic investment in society. Although redlining was banned over 50 years ago, its legacy still shapes health outcomes today. By designating Black and immigrant neighborhoods as hazardous, these policies have locked communities into cycles of disinvestment with effects that extend well beyond housing. A 2023 study of more than 2,000 New York City census tracts found that historic redlining is independently associated with higher stroke risk, even after accounting for traditional social determinants of health. This illustrates how structural inequities of the past, and this is depicted on this slide, how these structural inequities of the past continue to produce measurable adverse health outcomes in the present. Redlining may be illegal today. Its downstream impact continues to shape the health of entire generations. New York City remains a tale of two cities, where zip code determines exposure to adverse social determinants of health. And I want to emphasize, determines exposure to adverse social determinants of health. In the Bronx, 1 in 4 residents lives in poverty, with household incomes as low as $27,500 in the South Bronx. In Brownsville, nearly 30% of residents live in poverty, and unemployment tops 10%. These inequities, due to adverse exposure to social determinants of health, translate into adverse health outcomes. 17% of Bronx residents are uninsured, compared to 7% in Staten Island. 33% live with obesity versus 17% in Manhattan. And 57% in the Bronx are rent burdened, compared to 43% in Manhattan. In regards to smoking, 17% in Staten Island compared to just 8% in Manhattan. So in New York City, where we sit today, in this slide, we see life expectancy across races and also correlated along neighborhood poverty. We see an overall average life expectancy of 83 years of age across white, Black, Hispanic, and Asian Pacific Islanders in New York City. There are demographic variations when that number is unbundled. Life expectancy is 78 for Blacks, 83 for Hispanics and whites, and 87 for Asian and Pacific Islanders. And to the far side of the slide, we also see that life expectancy is correlated by neighborhood poverty, with the highest neighborhood poverty driving a life expectancy of 78, and the lowest driving a life expectancy of 85, indicating that race alone is not predictive of life expectancy, but socio-economic status also plays a role. We know that all races live in both low and high poverty neighborhoods, and therefore, this story is not just about race, it is also about place. Now, this slide broadens the lens to show how social determinants of health vary across New York City's 5 boroughs, revealing significant pockets of vulnerability, pockets of health vulnerability. Compared to the New York State performance shown to the far left of the slide, shaded in dark gray, you see New York City performance in the adjacent column shaded lighter gray, showing overall lower rates of elementary school absenteeism and incarceration, but higher levels of limited English proficiency and food insecurity. The Bronx, shaded in the reddest, emerges as the most vulnerable borough, with the highest rates of school absenteeism, language barriers, food insecurity, and incarceration. Queens shows a mixed picture. It has the lowest elementary school absenteeism, the highest percentage of residents with limited English proficiency. Staten Island and Queens to the far right both perform better on food insecurity and incarceration. Now, these social determinants of health differences make clear that health inequity is inseparable from socioeconomic inequity, and both are highly predictable of and correlated with health outcomes. Geography should not dictate destiny, yet just 8 miles apart, residents of the Bronx, depicted in the red shaded stats, these residents face radically different health futures than those in Manhattan, in the green shade, 8 miles apart. Life expectancy drops by nearly a decade, diabetes prevalence quintuples, poverty rates more than triple. These are not random outcomes. These are predictable consequences of unaddressed social determinants of health. These outcomes should not surprise us. Advanced analytics and artificial intelligence now give us the tools to identify these patterns in near real time, if not in real time, and allows us to intervene proactively. The issue is no longer whether we can see the disparity after the fact and remain fixated on the racial and ethnic component. The issue should be whether we're willing to act on what the data tells us the data predicts will come before adverse outcomes actually play out. Now, health inequities persist due to a layered interplay of upstream political forces, midstream social determinants of health, downstream patient-provider interactions. Students of public health, you all know this. Now, political determinants of health, you should be familiar with that term if you're not, such as federal laws, executive orders, judicial rulings, and state policies. These all shape resource distribution, accountability for execution, and access to healthcare. Examples of political determinants of health include such as states refusing to expand Medicaid under the Affordable Care Act, or clawing back from Medicaid in contemporary times. Efforts to roll back school vaccination mandates. These are examples of political determinants of health. Now, we have to remember structural inequities that are rooted in historical policy. These drive implicit bias and racism. And in turn, they shape unequal exposure to enabling or adverse social determinants of health. We have to be able to understand that there are enabling social determinants and there are adverse social determinants. And depending on the ecosystem that one is birthed and immersed in, if your social determinants are enabling or adverse, you have predictable health outcomes. The health risks that arise from adverse social determinants often accumulate long before a patient enters the healthcare system. Once they do within clinical settings, limited workforce diversity exists, poor cultural competency, provider bias, all compound inequities across outcomes: cancer, cardiac disease, maternal health, and more. CUNY's ecosystem demonstrates strong commitment to health equity, with investment in research hubs, NIH-funded centers, and community engagement programs targeting Harlem, the South Bronx, and other under-resourced populations. These initiatives have advanced culturally relevant monitoring, they've embedded intersectionality into policy and practice, and they've deployed tailored interventions from vaccine literacy to chronic disease research. Despite notable progress, the challenge remains moving from promising pilots and localized impact to scalable system-wide solutions that can meaningfully close care gaps across New York City and beyond to New York State. Since the Institute of Medicine's Unequal Treatment Report in 2003, awareness of health disparities has driven nearly $200 billion in investments through 2023. It's a 20-year timeline from the awareness of unequal treatment in 2003 to understanding that about $200 billion was invested in public health programs, initiatives, and an attempt for systematic reform to achieve health equity. $173 billion came from the government, $4 billion from philanthropy, and $2 billion corporate foundations. This does not add up to 200, it is close, but this was publicly available information that we were able to glean when I was at the EY Center for Health Equity before I retired a couple of months ago. Now, shown on the left half of this slide, this information I just mentioned was published in a white paper, and it demonstrated that despite decades of funding, the proliferation of health equity centers, as shown on the right-hand side of the slide, in which you can see CUNY, Institute for Health Equity, is well represented, adjacent to NYU Langone's Health Equity Institute, despite a plethora of formalized health equity centers across the country over the past 30 years at least, persistent health equity gaps remain. With that funding, we should also ask ourselves, what benefits have we accrued? So, for example, while breast cancer mortality has declined for both Black and white women since the 1980s as a result of population health interventions, the disparity, mortality gap between Black and white women has not narrowed since the early 2000s. And the same trend is evident in cardiometabolic disease and maternal health and others. It raises a critical question. Why, after so much investment and institutional activity, have we failed to close gaps? Are health equity centers designed, resourced, and supported with business cases strong enough to drive compelling systemic impact? Or are they still operating at the margins of enterprise strategy and innovation? The field of health equity remains hamstrung by a lack of standardized metrics, fragmented reporting tools, inconsistent regulatory expectations. This all combines to make true progress difficult to measure or reward. And despite a growing array of frameworks to monitor health equity activity from CMS, NCQA, the Joint Commission, to the likes of Vizient, US News and World Report, and others, still today there is no unified model that exists to evaluate impact across systems. Lack of cohesion has real consequences. For example, what do we glean from the finding you see on this slide from US News, that among the 53 hospitals named to the 2024 Best Hospitals for Equitable Access list, just one is in New York, in Queens, New York, to be exact. Understanding New York City, Manhattan in particular, is home to some of the most globally recognized medical institutions. What message does this send to our health industry? If we're to believe this information, obviously, prestige alone is not a proxy for equity. Indeed, it may mean that prestige is a disabler for equity. Must remember that what gets measured drives what gets prioritized. Now, this slide spotlights where too many health equity efforts stall in what we call the activation gap. We see in this slide that we do well in the green zone on the left, the pre-activation phase. Research and policy are essential. But without real-world pilots, absent of scalable business models, and devoid of intentional financing, impact never materializes. Translational research must be coupled with proof of concept validation, with clear, easy to understand, directionally accurate return on equity for society, return on investment for organizations, by extension for our people. Closing this gap requires coordinated strategy that is inclusive of investment, be it through venture capital, private equity, innovation grants, and federal and state funding. All must be aligned, de-risk scale. If not, health equity will remain aspirational until evidence is not only compelling, but commercially and operationally viable. Scalability lives at the intersection of outcomes and investability. Now, the pursuit of health equity has come under political attack, as we well know, with recent regulatory progress meeting political pushback against health equity. As of January 2025, however, as we see in the left panel of this slide, there was broad alignment in support of regulatory expectation in favor of health equity across CMS, the Joint Commission, the FDA, NCQA, and others. More recently, though, as seen in the right-hand panel of the slide, we see states on track to end health coverage programs for immigrant adults, May 2025. The Trump administration scraps research into health disparities, August 2025. States Medicaid pilot off to a slow start as federal funding cutoff looms, July 2025. We've seen a targeted dismantling of DEI initiatives, the systemic defunding of public health grants and medical research. We've seen layoffs across federal health agencies, undermining of evidence-based treatment, widespread misinformation, and threats to public health insurance programs, including Medicaid and Medicare. And as is seen at the bottom right corner of this slide, at least 14 states have a plan to file demonstration waivers for Medicaid work requirements. So we're seeing in real time the risks of framing health equity as just a moral obligation, or the risk of pursuing just academic discourse funded by DEI grants. When the narrative is narrowly focused on race alone, or when the narrative is tied to discretionary research and DEI funding, we're seeing that it fails to achieve sustainability or long-term engagement. To drive systemic activation, I challenge you to understand that health equity must be reframed as a strategic imperative, anchored in a defensible business case, and it must be embedded into the core operations of health systems across the value chain, provider systems, payer systems, life science systems, public health systems. Only then does equity move from optional charity to essential enterprise value. So in this section, I want to challenge us to reframe the health equity narrative. Health inequities are not just racial problems, they're an all-American problem. For too long, social determinants of health, access to care, education, housing, food security, unemployment, and safe communities have been narrowly framed as issues facing only and predominantly Black and Brown Americans. This is a distorted narrative. I will say that again. This is a distorted narrative. And it has fueled inertia and systemic inaction, leaving all Americans vulnerable for poor health outcomes. At the same time, a counter-narrative has blurred health equity into the broader DEI debate. And this has been done by a masterclass of distraction, deflection, and misinformation. We allow that framing to stand on both sides of the equation. Both health equity and DEI risk being dismissed together, casualties of a well-designed campaign against societal uplift. Consider the following social determinants of health stats that I shared earlier this month in a LinkedIn post. Looking at absolute numbers and not percentages of racial and ethnic demographics in America, when it comes to Medicaid enrollment, 40% of enrollees are white Americans, 21% are Black Americans, 30% are Hispanic Americans. The largest Medicaid enrollees in America are Caucasian. Recipients of SNAP benefits for food insecurity, 37% of recipients in America are white Americans, 26% are Black Americans, Hispanics 16%. Uninsured population, health uninsured population in America, almost 40% are white, about 12% are Black, and Hispanic about 40% too. Food insecurity, 35% of the population are white, 26% are Black, Hispanic 16%. 50% of homeless Americans are white, 37% are Black, Hispanic 28%. I wrote a LinkedIn post recently where I described gun violence as America's newest social determinant of health. 56% of people that die from gun violence in America are white, 30% are Black, and Hispanic 13%. You may be aware of this as your public health students, but I can guarantee you the world does not know this. Without sharing this sobering reality that numerically more white Americans are exposed to the impacts of adverse social determinants that ultimately will manifest as poor health outcomes over time than Black and Brown Americans. The narrative on social determinants of health is incomplete, and it indeed is misleading. Health inequity, or health disparities, whatever we want to define it as, is an all-American problem. It is categorically not a Black and Brown problem alone. Indeed, the data is suggesting that it is more a white problem and a Black and Brown American problem. So for truth to be told, we must be reminded that health disparities in the Black and Brown community They do stem from centuries of structural racism embedded in US policy and the practice of medicine. It goes back centuries from slavery through Jim Crow, when the US health system was deliberately designed to be unequal. And this intent was reinforced by laws and judicial rulings. Political determinants of health, a term that was coined by Dr. Daniel Dawes, professor of global public health at Meharry Medical College. These policies barred African Americans from full citizenship, shaping fundamentally all the inequities we see that are still visible today. Furthermore, the American medical profession itself was complicit, from unethical experimentation on enslaved people to segregation of hospitals. You're all familiar with the 1910 Flexner Report. This was commissioned by the AMA, financed by the Carnegie and Rockefeller Foundations. This Flexner Report shuttered nearly all Black medical schools, with the exception of Meharry and Howard, restricted Black physicians to caring only for Black patients, branded Black physicians and nurses as inferior, a stigma that lingers till today. During the Civil Rights era, AMA fought actively against Medicare and Medicaid, even as Black physicians demanded reform. Only in 1966, under Title VI of the Civil Rights Act, were American hospitals forced to desegregate for fear of financial penalties afforded them by the very Medicare and Medicaid that was resisted by the AMA. And this desegregation of America's hospital is what prompted Dr. Martin Luther King Jr.'s famous words, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Now, these are uncomfortable truths. They are essential ones that must be reiterated, not to point an accusatory finger, but they must be remembered so that they become understood. In 2002, the Institute of Medicine's Unequal Treatment finally provided incontrovertible evidence that systemic racism and adverse social determinants drive disparities, validating what communities had known for long. So to work in this space, we must have a willingness to be educated, we must learn to be empathetic, and to understand and then embrace these truths. Indeed, the rapid and effective desegregation of American hospitals, 1 year after Lyndon Johnson signed Title VI of the Civil Rights Act, was one of our nation's and our healthcare system's most shining moments. This was achieved by persistent political advocacy from both Black and white activists, designed to protect the vulnerable. It was pushed over the finishing line by bipartisan legislation, demonstrating collaborative traits that we should embrace more transparently today. To close gaps today, we must confront this history, empathy, transparency, and we must muster the will to act. So here we ask, how can healthcare organizations unlock the full value of health equity within their enterprise? The $978 billion opportunity you see on this slide, tied to closing education-related disparities, is massive. And it is directly related to health literacy as a competency for aspiring towards healthier lifestyles, healthier decisions and choices, and toward optimal health outcomes. The health literacy, 12% of Americans have the highest level of health literacy, 12%. And that tells us that America as a whole has a problem with health choices, and by extension, with health outcomes. So the way this context is framed the 978 billion, it keeps it out of reach of the grasp of individuals or system leaders. If you look at national figures on the right-hand side of the slide, that speaks to 645 billion in avoidable premature deaths and 157 billion in medical savings. These numbers may resonate with policymakers, but they don't translate to the operational realities of hospitals that are managing margins, trying to stay afloat. It does nothing for the senior vice presidents, the vice presidents, and directors that are managing service line costs. The challenge and the opportunity lies in reframing this macroeconomic potential into localized enterprise-specific outcomes that are concrete, measurable, and tied to financial sustainability of specific organizations. So let's, for a moment, focus on the 157 billion in potential medical cost savings. While powerful at a national level, this number is far too abstract to guide decisions within a health system, as I've mentioned. Leaders in the health systems aren't tasked with managing the US economy. They manage service lines, they watch margins and care delivery within the bricks and mortar of their health systems. So to secure C-suite buy-in regards to developing strategies for health equity, the conversation must shift macro to micro. And here's the question. How do we correlate reduced readmissions, the potential for optimized reimbursement through value-based care delivery? How do we reconcile workforce productivity or competitive market share with health equity? Until this value is localized and tied directly to enterprise ROI, these national figures will remain distant aspirations rather than actionable business strategies. Using publicly available data, we identify a total annual financial opportunity of 157 billion associated with closing disparities across specific high burden conditions across the country. When this opportunity is further customized to a specific national payer, the opportunity, and these are real numbers from the work I was involved in at the EY Center for Health Equity. The opportunity for a particular national payer totaled 5.7 billion across priority conditions. And strikingly, nearly 90% of this $5.7 billion opportunity is concentrated in just three areas: cardiac disease, metabolic disease, and chronic kidney disease. Now, understanding this particular opportunity for a national payer now makes sense to the C-suite. Per member per month utilization reductions can be estimated. The business case becomes even more tangible. This enables payer organizations to project the direct financial upside of targeted interventions, to also do a cost analysis of those targeted interventions as an investment, having insight into an ROI. Closing equity gaps in these priority conditions not only reduces excess spend, but it unlocks strategic value in the form of improved outcomes, stronger member engagement, and long-term cost containment. Health equity business cases not be one size fits all. The value proposition looks different for each stakeholder. For providers, it is better resource allocation, providing the right care in the right place at the right time, and benefiting from risk-based payments. For payers, it's preventative care by way of earlier diagnosis and timely intervention that reduces costs and improves member satisfaction. For life sciences, it is diverse clinical trials and inclusive R&D that accelerates innovation. For public health, the stronger community engagement, investments in social determinant of health interventions, accessible community health centers that de-risk disease vulnerability, that promote health literacy, that promote primary prevention, and by investing in programs that drive awareness of healthy behaviors. And for large employers, it is how do we move from health benefits being just that, just benefits, to utilization of health benefits, to understanding the utilization of health benefits by the workforce, and providing a platform for the C-suite to understand the health and resiliency of its human capital so as to get to a healthier, more productive workforce. The lesson is clear. The macroeconomic value only matters when translated into sector-specific local strategies that drive real incentives and measurable return on the investment. Advancing health equity externally requires first building capacity internally. This means equipping the workforce with knowledge and tools, embedding equity into every function, and aligning on universal goals while recognizing that different populations face different barriers. This approach of targeted universalism, you probably are familiar with that word, a social and design principle where policies or physical modifications are created to benefit a specific vulnerable group. But it also highlights how by doing so, investments in one group over time improve overall well-being of all groups. Targeted universalism provides a common standard for all while tailoring specific strategies to ensure that every group can reach them. When equity becomes part of daily operations rather than a side initiative, it drives measurable impact, it drives enterprise value. So achieving meaningful progress on health equity requires moving from aspiration to strategy. This framework, you see, lays out a disciplined process. It prioritizes clinical focus areas, sets measurable objectives, calculates both investment costs and savings. It allows you to build a financial ROI model to show impact over realistically 3 to 5 years. It aligns initiatives to available resources and then develops a compelling narrative that resonates with stakeholders. In equity, innovation is tied to data, financial modeling, and strategic communication. It stands a good chance of shifting from moral aspiration to operational and economic imperative. As I've said, building a business case for health equity starts with localized clinical insights. National data from another health system footprint shows cardiometabolic disease, cancer, and maternal and child health as the most pressing priority disparities within this footprint, with chronic lung disease and mental health also critical. The priority for any health system should come from its own geographical footprint, mapping local prevalence, organizational cost burden, outcomes gaps. A structured prioritized matrix, as you see here, helps target interventions that not only close health equity gaps, but also deliver measurable ROI and enterprise value. Unlocking health equity value requires moving from broad commitments to structured action. We must. Just one more second. Well, the message here is that you can't boil the ocean. The truth be told, that if you paste diagnoses on the wall, the entire wall, you name it, and you start throwing darts with your eyes closed, wherever it sticks, you are likely to find disparities that are skewed to the disfavor of Black and brown Americans. But if you then look at the numerical, you will then find out that there are more white Americans that are also at risk for these disparities.
Is that a reflection of the population? Isn't that a reflection of the population ratios? I mean,
I'm sorry?
we talk about numerically more white people, but there are numerically more white people compared to Blacks. So that is merely reflecting the
It is. It is reflective of the population, but it does.
the intensity of, for example, food insecurity or
Not necessarily. I mean, the social determinants of health, adverse SDOHs impact more Caucasians than we are willing to acknowledge. And of course, there is a whole area of rural health. Whole area of rural health that if systemic interventions are put in place, begin to essentially level the playing field, irrespective of who is living in rural America.
Very interesting, which is alignment, health system priority. For example, let's take mental health, and the circle is half, meaning that it is not fully aligned with health system priorities.
This is a particular organization. This is not hypothetical, and this is not research. This is input from the health system leadership. This health system priorities, it's not that mental health is not a priority. It is less of a priority than this. It's less of a priority.
So it's a comparative.
It is, and it is designed to understand which do we address first. Not that we don't address this in time, but an objective framework to help us make a decision. Where do we invest our dollars to demonstrate proof of concept?
It's a very, very interesting slide. I've never seen anything.
Well, this is also reflective of the stigma and the taboo.
Yeah, it's very convincing. I'm just saying I've never seen the data presented exactly like that, comparing prevalence to alignment, to maximum racial disparity, to age adjustment mentality. These are four very interesting dimensions.
Yeah.
How did you select these four dimensions, or how were they selected?
Talking to clients, understanding prevalence.
Sorry to ask.
No, that's fine. Understanding prevalence across these dimensions, understanding the economic opportunity if gaps were closed. It was a multivariable matrix that was used. And understanding the pulse of payer organizations and provider organizations. Ma'am, did I finish answering your question, ma'am?
no, I mean, I just think the denominator is important as well as is equally as, if not more important than the numerator. So if you just look at the absolute numbers, or what you're calling comparative numbers, then of course there are more white people. That translates to having more poor white people.
Not necessarily, not all white people. More.
I said the denominator is important.
What you said is true, but it does not mean that the white people that are at risk are poor. It just means that there are more white people than we care to understand. And this is not about the percentages of the population. No, it's not the percentages of the population. It's the absolute numbers I'm talking about.
Like risk difference versus risk ratio. If you want to help the most people, you need to look at the numbers and see who are the most impacted.
Yes, sir.
Yeah, just a comment from online, when questions are asked, if you don't mind repeating the question, Dr. Aluko, because they're having trouble hearing questions from the audience.
Okay.
Thank you.
Got it. Got it. We can talk offline because I see you are still quizzical. Right. All right. Are we good? No, it wasn't published. This is work that my team did. So unlocking health equity value requires moving from these broad commitments to structured change and action. First, making equity a strategic priority, not an off-ramp activity. Assess the organization's maturity to understand its current capabilities. From there, the path becomes easier. Define a data-driven equity strategy, build a defensible business case tied to a financial ROI, and ensure sustainability through governance, measurement, and incentives. When health equity is integrated into core strategy, it shifts from a moral aspiration to a driver of business value and long-term impact. Now, here's a hypothetical business case for a New York City health system, which was modeled with actual reported 2024 financial performance numbers for this institution, not this institution, for an institution. Let us consider a 2024 $14 billion annual revenue, operating with a $430 million profit and an operating margin of 3%. A 3% margin is a good place for a provider health system, not-for-profits, to be at. Considering that the median operating margins are between 1.5% from fiscal year 2024, reported by Moody's, and 1.2% reported by Fitch Ratings. Now, a financial modeling approach, and understand this is a modeling approach that is going to be advanced into the C-suite with the CFO to help build a directionally accurate business case for health equity by identifying opportunities to drive revenue and to reduce costs within prioritized clinical conditions, such as cardiometabolic disease, oncology, maternal health, mental health, whichever domain the health system wants to start with. Because you can't boil the ocean. Strategic investments in primary and preventive care, earlier diagnosis, going from the left of this slide to the right. Coordinated care can reduce avoidable hospitalizations, reduce unnecessary admissions, temporarily decreasing patient revenue, shall we say, by an estimated $800 million for a health system that is generating $14 billion. It's a conservative estimate. Now, while this reduction may appear risky, why should a health system want to reduce its revenue? We're talking about inappropriate admissions or avoidable admissions. By so doing, it positions the organization to replace and exceed that loss by diversifying its revenue streams, by focusing on value-based care and capitalizing from value-based care reimbursement, by focusing on lower costs sites of care, virtual care, home care, by focusing on quality incentive payments. Net result, revenue climbs from 14.2 billion to 14.6 billion. Now on the cost side to the far right, increased spending on equity enabling capabilities such as technology, infrastructure, platforms, repurposing skilled workforce, new partnerships. That's an increased spend, but it is offset by significant savings from the reduction of uncompensated care, by minimizing clinical variation, which is very expensive, by overall efficiency gains. So total expenses drop pathetically from 400 million to 200 million. And the outcome is a financially healthier organization, 14.6 billion in revenue, 13.9 billion in expenses, net revenue of 730, a positive 5% margin, proof that equity and sustainability can exist. And by so doing, the health system is in a better financial position than it was. These health equity initiatives need to be turned into scalable and sustainable programs across all dimensions, within adult and pediatric clinical service lines, within hospitals and health systems that are positioned to do this work across all specialties. It requires execution of a well-formulated strategy that requires investment, financial modeling, and includes transparency of performance and accountability, strategy that demands accountability across the board. But the work begins before people get sick. Public health has the larger role to play in doing so, in addressing health risk and by attenuating health risk. at addressing the social determinants of health. Scalability will depend on proof of concept, advocacy for new billing codes for SDOH interventions, and cross-specialty resources to drive economies of scale. Scaling health equity solutions requires more than good intent. Demands a disciplined pathway from proof of concept, proof of value, to proof of demand, and finally, methodology to scale. Early pilots must be done and validated. Measurements must establish credibility. Success hinges on moving beyond journals, moving into partnerships, moving into regulatory alignment, into alliances with accelerators that prove market demand. From there, growth capital, a hub and spoke model, digital platforms, cross-sector storytelling can all drive speeds to execution for widespread adoption. This staged approach ensures equity solutions are not only effective, but they are investable, scalable, and sustainable. So as I draw from our reframed narrative, permit me to take liberty to say the following. We must expand the narrative to understand the broadness of the demographic vulnerability for health equity beyond just race. We must understand that it also includes place, not just race. Health equity will be achieved when the broader vulnerable demographic beyond just the racial impact is understood to be an all-American opportunity. We must begin to embrace the reality that there are numerically more white Americans exposed to adverse SDOHs that drive bad health outcomes and economic consequences of that than Black and brown Americans numerically. We talk about race, ethnicity, religion, immigrant, elderly, homeless, rural geographies, immigrants, and more, all are vulnerable. Solutions must be built to be universal and not just racial. I will emphasize that all Americans are at risk for in-country and global disparities. Now, Black and brown people may fare worse than whites, percentage-wise, but the burden on white America in of itself, numerically, is more compelling. It is acknowledged that systemic SDOH interventions and addressing the political determinants of health are key, becomes clear that place, not just race, matters. So a wise man once spoke these powerful words when he said, "Before I die, I want to see the needle move on health disparities in this county. I'd like to see an awareness amongst young people who embrace this issue and contribute toward changing it." That wise man, erudite physician and scholar, is Dr. Ayman El-Mohandes, Dean of your CUNY School of Public Health. I'll take liberty to extrapolate from his words and close by saying, race, place, nor condition should matter in a patient's treatment. There should be race, place, and condition blind. Thank you kindly for your attention. Any questions? Yes, ma'am.
I used to do a lot of community work, so I'm kind of aware of like quips and audit improvement plans, and usually they're tied to an incentive, right? Whether it's for the hospital or directly to the physician. How do you feel like in your experience, incentive played a role in the intervention that we want to execute? And like, are there plans that maybe don't have an incentive tied to it that can still be implemented?
Incentives always motivate. Incentives have to be measurable. The performance from the incentives have to be accurately measured. That requires very efficient technology platforms that do not create more confusion. And depending on what you're measuring, if that measurement is taking into account the complexity of the patient, one incentive may be achievable in a certain diagnosis and a certain patient population. So customizing all these variables becomes very complicated, and that is one reason why they have not been sustainable. But fundamentally, putting incentives in place for performance gets attention. If the incentives are realistic, the opportunity to gain from it is realistic, and if the data analysis is accurate. Yes, ma'am.
Slide you had in this conical slide, starting from scientific evidence to policy change. And I'm wondering if we have even one model of something where we're able to achieve this kind of transition. That one, yes, next one. You know, starting with research and policy development all the way to proof of value and then funding implementation scale. Are there any examples? Because this is the optimized model, isn't it?
It is. Are you asking any examples of success? Well, they say that, as I mentioned earlier, there are some states in the US that are demonstrating best practice within the US. Now, the US as a whole is not best practice, and it should be based on our economy, our level of sophistication. But there are models that the rest of the country should understand what those critical success factors are. But to answer your specific question, the health equity issue is a subset of the dysfunction within the health industry. We talk about the health equity issue. The focus has been on research. For decades, it's been on research and the economic implications have been out there, but like I said, they haven't been distilled down to get attention. And if you have a C-suite that feels that it needs now to develop strategies for Black and brown people, it's first of all, you have to process in your head that you're admitting that you aren't doing things equitably, and therefore you have to now customize a process for Black and brown people. It is difficult to tell a doctor to behave differently when a Black or brown person enters his or her office. Because doctors presume, and they should, that they treat people the same. But the truth is that when I'm talking about a larger number of Caucasians, what I'm saying in essence is that the health industry is not putting best foot forward for all Americans. Okay. The narrative is a narrative that, in my humble opinion, has been informed by implicit bias. You know, there are many Americans of all stripes that need help with health literacy, with healthy choices. They need help with health access, with chronic care management. It's a fundamental industry problem, operations management problem, a coordination problem, integration across sectors were very fragmented.
Yeah, the only problem that I see with this argument, to be very honest with you, having worked in Nebraska, for example, and experienced what you described in terms of rural population not being offered the same kind of services, that the distribution of inequity is not geographically uniform. So if you're talking about, certain neighborhoods in New York City or Washington, D.C., or even Los Angeles, the representation is not the way you describe in the general terms. Because of course there will be a skew that's racial and ethnic in nature.
Correct.
And yes, the physicians will have to address populations based on the racial and ethnic affiliation because there is underlying systemic issues that are targeting these populations. While, the physician in rural Nebraska may not be faced with the same kind of. So my fear of this argument is that it takes away the responsibility of tailoring the form of healthcare delivery that is knowledgeable and cognizant, but also responsible and accountable for the health of certain segments of the population that historically have been sequestered and disenfranchised.
I'm not minimizing the experience and the historical narrative, not at all. Yes. What I have said today is provocative anytime I say this, and it gets us thinking. The issue that you need to understand is the narrative. You haven't even, I would be surprised if every single person here has actually thought about this before today. There is an opportunity here for us to focus on driving benefits for all. And it's going to be a systemic process. And if it is systemic, it may be informed by what competencies do we need to help address the health needs in Harlem, New York, that has a very specific racial and ethnic predominance. But whatever we do in Harlem, New York, if we do it in a manner that can be scaled, it will work in Nebraska. That is targeted universalism. It will work in Nebraska. It's different cultural nuances. But it is creating platforms of accountability, performance visibility, access. Now, we can't create universal access to healthcare. We in this room cannot invest money into schools and transportation. That upstream driver aspect, that for some reason, I think many of you might agree with me that in Washington, D.C., there may be a perception that stripping Medicaid is going to affect more Black people than white, but it's the reverse. And I'm saying this because it was on CNN when senators and others were surprised. I'm not trying to be racially provocative. I am saying that the problem we've been talking about for the past 50 years that has been coined as a Black and brown problem is actually not just that. It's an American problem. Yes, ma'am.
I was curious that one of your ideas in the budget was just adopt value-based care.
Yes, I'm glad you said that.
As you know, that's a many multi-year cultural change in even a small hospital, and certainly in the big health systems, as you know, you're seeing more and more of that. So that was one part, and then the other part is if you had a slide to say, here's what I would suggest to the payers based on our research, what would it say?
All right, I'll come to that in a minute. Now, this issue about value-based care, population health, value-based care, clinically integrated networks, all these soup salads, they're all the same thing. Health disparity elimination, health equity, essentially is value-based care, it's population health. But over generations, we adopt something that's more sexy, and we don't execute on any. I was a fellow here in New York City, initially at Columbia, and then at New York Hospital. There's this organization called the Association of Black Cardiologists, of which I'm a member. I was a fellow, and that's when I began to hear provocative rhetoric about racism in cardiovascular medicine. There were seminars that were being held at the American College of Cardiology and the Society for Cardiac Angiography Interventions that I used to go to. And the ABC would put on these seminars, racism in cardiovascular medicine. A room as big as this, you have probably one Caucasian person and 40 Black and brown people. Why would a Caucasian person come into a seminar that is implicitly accusing them before they walk through the door as being racist? Why am I saying that? It morphed from that racism in cardiovascular medicine to elimination of racial and ethnic disparities in cardiovascular medicine. That became more of a research context. So I observed, this is a societal experiment, more Caucasians of interest were coming to those researchers. Now we're talking about health equity. I don't like the term health equity, to be honest with you, because it's aspirational. It has never existed in American medicine. And how does health equity even exist when there is no societal equity? So to be very clear, we're talking about reality here. But health equity caught fire during COVID. That is why the Center for Health Equity at EY was named that, because the world embraced it. But we see now that that issue of equity is now raising different signals in different circles. Okay? Regarding what we tell a payer, we know that the current business models work for the current sector incumbents. Health insurance is a simple formula of taking in membership coverage dues and spending less. We know that there's tremendous waste. We know there's poor accountability. What we also do know is that 55% of insured Americans are covered by large employers through commercial insurance. When we talk about payers, I think that it is the large employer that can be that catalyst for transformation by holding more, having more accountability. But that takes a very significant strategic change in thinking, where currently large employers provide health benefits as an employee benefit. That's it. It's a benefit. It's a tool to attract you to come. There needs to be a strategic shift where large employers now think of this not as an HR issue, but a C-suite issue. If we're spending this amount of money on health benefits, we need to know who is spending this money. And are people using our benefits appropriately? Are people getting annual exams? If we have, data can tell us that we have 5,000 women that are at risk for breast cancer. From claims made, we can tell what percent is getting screened. No? So moving from HR to the C-suite, so there's surveillance of the health of the workforce. Why? Not to spy. And this can be done anonymized. It is being done because the health of the workforce provides resiliency for the business. It is difficult to change the current business models for payers for any of the sectors because we are vested in the status quo. There's a fair amount of inertia. We've been talking about this for decades. I think the transformation is going to come from the outside, like a large employer.
We have a question online. Do you have any experience with successful large-scale approaches to addressing the gap in health literacy? What challenges and opportunities stand out for you in that area?
I don't know of any large-scale approaches. theoretically, we know what those approaches should be. Health literacy is not a racial problem. It is an American problem. Like I said, Pew Research reports last year, 12% of Americans are proficient in health literacy. It's education. It's education, it's access to healthcare, it's community penetration, it's investment in social determinants. Now, large scale hasn't been done. If a country does not have universal access to healthcare, there's going to be a chunk left behind. And those that have it, the fee-for-service world will be very discriminatory about how they use it. So there are theoretical constructs. I'm not aware of any. I know there are no existing large-scale constructs because we are where we are today because there are none. Yes, sir.
Thank you for the presentation. 2 questions ago, you mentioned that you didn't like the term health equity because there's broader societal inequities. But isn't part of the principle of health equity that within healthcare you sort of anticipate those and almost compensate for those?
Well, not because there's broader societal inequity. I don't like it because it became a buzzword and people didn't really understand what it meant. And I know this for a fact because I've worked in this space, both in my first career and my most recent career. People did not really understand the genesis of health disparities in Black and brown people. People did not understand the disparities in rural America, and people were not willing to acknowledge that even in Midtown Manhattan, there could be risks for people that have access to healthcare. So it's really, for me, it was people just running with this terminology and it was sticking. Yes, ma'am.
Thank you for the talk. My head is spinning, so hopefully this will be coherent, but with the rise in the politicization of everything right now, and what you've mentioned in terms of Medicaid cuts, for example, that are going to affect white pockets of the country, white Americans in great numbers, but we see politicians not really acknowledging that the changes they're making are going to directly impact their own communities, because they're tying this all to a racial equity lens that they're trying to distance themselves from. What can we do now? Like, which of these wonderful and thought-provoking ideas do you think will be the greatest opportunity for people who believe in all of this, but who feel really overwhelmed with like what could be a long-term outcome of our current political environment?
So the question for the online audience, I'm sorry I haven't been repeating them, is what do people do? What can we do to be part of the solution? This whole construct is dizzying, it's confusing, and it's polarizing too. I think that as public health professionals, your positioning in society places you in a very strong manner to be an advocate, as well as to be an executioner, depending on where you sit eventually when you into the full-time workforce after all your studies. I know some of you are working already, but I think fundamentally you need to find your lane. Because if you feel that you are going to be able to create systemic change alone, then you will get disillusioned. I think you need to find your lane. Are you going to work midstream, downstream? You're going to try to work upstream, where upstream you're dealing with advocacy, downstream you're dealing with execution of funding and attenuating social determinants of health. Downstream you're dealing with accountability of performance and so on and so forth. Where are you going to be? And when you decide where you're going to be, you have to develop networks, relationships, understand the space, develop social capital, be influential, The work is hard and long. And I was telling Adam earlier today that always these peaks and troughs of embracement, primarily driven by social obligation and the economy. But since COVID is the longest duration, it's been 4.5 years, that this has been in the forefront, okay? COVID, George Floyd. I also mentioned that reason why it has been in the forefront, the tipping point was not from the health industry. It came from investigative journalism. It came from the commentary every single day during COVID about health disparities between Black and brown people and Caucasian people, more Black people dying from COVID. Okay. There is still an inertia within the health industry to be transparent about its failings. You know, we are all patients or will become patients. The customer experience in the health industry is not a great one. If you have need for chronic attention, it is expensive. The outcomes are not very clear, and we have a lot of work to do. As public health practitioners, you need to lock arms together, identify your space, go deep in your insights, and develop a soft power. Any more questions?
So another question online. As a clinician operating on the micro level in the mental health field, what are the best approaches towards establishing partnerships to help address some of the missed opportunities mentioned in your presentation?
I can speak to the observation that one of the hardest places to have this conversation is at the front lines amongst doctors. If you think about DEI conversations, and DEI is separate from health equity, there's overlap. An organization that embraces DEI principles is more likely to develop cultural competency within that organization, and its providers are more likely to be culturally competent. But DEI conversations are not generally permeated within physician enterprises because physicians, depending on the organization, because some organizations will mandate it, physicians tend to say, I treat all patients the same. Okay, so what should physicians do? Think that there needs to be an awareness that everybody has bias. You know, and there also needs to be an awareness that cultural competency can be learned by anybody. There is some data that suggests culturally concordant care. In other words, a Black patient seeing a Black doctor gets better care. You know, I question that. I know that it's a comfort zone and but there's a presumption that every Black doctor is culturally competent and may not do the same with a Caucasian patient. On the flip side of the coin, there are some African-American doctors or Black and brown doctors that I know that are not good, empathetic physicians. 14% of America is Black African-American. 17% is Hispanic American. 5% of doctors in America are Black. There's no way you're going to get culturally concordant care because the numbers don't add up. Simple. Therefore, doctors have to be trained to be culturally competent. Have to be trained to be culturally competent. A Black doctor, an African immigrant, needs to be able to operate in Nebraska. Get through the biases that will be confronted, but needs to operate within the culture of the bubble you are working in. It's not a one-sided challenge at all. Just like I provocatively say, there are more white vulnerabilities numerically, there's opportunity within African-American, Black and brown providers as well. It's a 360-degree need The sooner we get to understand that, the quicker we'll begin to get on the right track. Any more questions?
Please join me in thanking our speaker today. Hopefully, we have taken a lot of lessons and a lot of things to think about in the future. Thank you for joining us. I hope we'll have many opportunities to interact with you.
Thank you very much.